All right, so I think this outline really demonstrating the risk profile of what we face with CTOs is helpful in terms of understanding how complications can occur. But there's lesion-specific levels, the approach of how we choose to do this, as you just saw, retrograde, putting hemodynamic stress on patients. LV dysfunction is a critical modulator of poor outcomes, and then clinical risk factors as well. So when we look at the current risk for CTO PCI, this is from the Open CTO study, which was 1,000 consecutive CTOs that were adjudicated. And perforation was 8.8%, in-hospital death 0.9%. This was probably in a more aggressive era. I think that was a lot of those complications were due to epicardial collateral perforation, and that's been recognized. And so rates have come down, but nonetheless, perforations are significant. One of the other really important aspects to recognize is that with complications, we can decrease our MACE rates by volume as we increase our success rates. And so this is an important aspect as one tries to maximize the success and safety of their programs. We have new risk scores. This has been read by the Progress CTO Registry, Manos Prolakis. We're a part of it. It's now got over 10,000 CTOs, and so it really offers a contemporary look at how to predict risk. And I think there's some limitations to risk scores. We don't always use it for every patient, but I think even just some simplest scores looking at, for example, aspects of age, severe, moderate to severe calcification, blunt, female, which is really important for both bleeding risk and shock, antegrade dissection reentry, and retrograde. These approaches, that's important to just kind of have an immediate sense that we're increasing the complexity as these factors get played in. And this has really kind of been validated, and now we have C statistics in the 0.6 to 0.7 range, reasonable for predicting risk. And these risks are really driven by kind of all-cause MACE. So just to list the procedural complications and some of the tools that are needed, perforations are the number one aspect of managing CTO complications, and we'll go through the toolkit. Donor vessel thrombosis, and I should also mention donor vessel ischemia, and you saw one way to protect against that by Dr. Ali's talk with mechanical support, but therapeutic ACTs are critical to maintain patency of the donor vessel. Stent deformation is something that probably is not talked about too often, but certainly from initial guide manipulation and guide extension manipulation, it's really important to recognize that longitudinal stent deformation can occur, and then actually during post-dilatation, delivering stiff balloons, there can actually be stretching within the stent, and that can lead to needs for restenting. So important to deliver those post-dilatation balloons gently and safely. Device breakage and retention, another major aspect, particularly in calcified vessels, and that can be really important for understanding, having a sense that devices may fatigue, both wires, stiff wires that knuckle are vulnerable, microcatheters that are overspun are vulnerable to tip breakage and retention. And then access site complications are another major source, and minimizing bleeding through ultrasound and micropuncture-based techniques can minimize those. So let's talk about perforations, which are the most frequent complication that we have and expected. When we have a perforation, I think, especially when they're elective cases, there is this sense that, it's hard to take a patient with electively and have destabilization. But this is the natural history of complex coronary disease. And rather than kind of, I think, beating oneself up about it, it's really just important to recognize they're going to happen and be skilled at managing those complications. So important to look at ambiguity as one of the most important risk factors. CT guidance ahead and intra-procedure can be helpful. Real-time IVUS guidance, understanding if a wire tip is ambiguous, if it's really not dancing in the architecture, that is the time to stop, not advance the microcatheter over that, because that can really lead to an insurmountable complication of bleeding. And then convert to retrograde early if ambiguity is not resolved, or use other techniques such as move the cap. Avoiding stiff wires. This is something that I think has been increasingly important for me as I've evolved over the last few years. Using stiff wires is something that is really now a very super focused and directed application. I much rather prefer to use knuckleable wires, jacketed wires, when I have questions of ambiguity. Avoiding epicardial collaterals, these can be approached, but really should be de-emphasized, particularly in first-time attempts, unless the patient's been extremely counseled. Recognize calcium and consider atherectomy, another important aspect, even in the subintimal space. And avoiding very aggressive post-dilatation, I think we've definitely seen that, and I'll show you a case of that next, where sometimes, especially using imaging, if one is not careful with the initial measurements, thinking about if one sizes EEL to EL, and one has a subintimal part of that, sometimes one can be overly aggressive and lead to perforations from the post-dilatation. So to be prepared, it's important to send a type-in screen. It's important to diagnose these perforations. Sometimes they're at the end of long cases, we're a little bit distracted and we're maybe celebrating that we're done. It's important to use unpanned still frames in multiple different angles to make sure that we're not missing an LS1 or 2. 3, of course, we're going to see. Heparin, not bivalirudin, because bivalirudin is not reversible. Have protamine available. In general, I reverse almost 100% of my cases to an ACT of around 200. I don't fully reverse unless I sense that there is mild amounts of bleeding that I see on echo and I know it's not going to expand. I may fully reverse in those situations, but it's important to check an echo at that time, and if there is a sign of a significant infusion, to tap before considering full reversal. Pericardiocentesis trays nearby. And to prepare your perforation toolkit, these consist of covered stents, really multiple sizes, and we're fortunate to have a new iteration of the covered stent, the papyrus stent. But in addition, we certainly can use graft masters. I'll show you a flow chart for how we manage these next. Coils are a super important part, and 014 coils that can go through microcatheter. We worked with our neuro IR group to understand which ones they were using and then just adopted those. And if coils are not available or not appropriate, having protocols for thrombin, beads, or fat or gel foam are also important. This is a good protocol, a good kind of flow chart from Colombo's group, just understanding that when a perforation occurs, the important thing is to stay calm and realize this is just going to be part of the natural history of the work we do in coronaries. Immediate balloon inflation proximal to the occlusion, obtain a secondary coronary access, central venous access, request blood, be prepared to tap, stat echo nearby, and page cardiac surgery for those who are surgically eligible, or if it's a gray zone, to definitely get their opinion. And then it's really about thinking about the branches that are going to be compromised when dealing with the perforation. If there's a large side branch that's going to be covered with a covered stent, that's probably the most tricky situation, and there are techniques where one can actually pre-stent the side branch to have a mark, cover the side branch with a covered stent, and then fenestrate that covered stent with a stiff wire. If one has the wherewithal to do that, that can be a successful way. That's particularly relevant if there's a left main distal perforation. Papyrus stent, which I know is not routinely available everywhere, is a really significant upgrade for covered stent delivery. Hopefully it will be universally available. It really improves the delivery in these stressful cases and can be used in 6 French guides and 6 French guide extensions in such situations. Just because of time, I'll fly through a few perforations. Here, this is the first case. This is a post-CABG right coronary, turned down for redo bypass, prior radiation lung cancer. JCTO of 1, crossed antegrade wire. And as we were post-dilating, which we used by IVUS guided, we went up to 4 or 5, probably on the more aggressive side. You can see here now an LS2 perforation here in the proximal right coronary. Because there was no significant side branch at that zone, we chose to, we did a prolonged balloon inflation. There was still a persistent leak, so we decided to cover it. There is some gray zone about this, about whether or not you absolutely need to fix this. You could use an echo guidance and decide if you want to fully reverse if there's a small effusion, but what we chose to do in this situation, and I think this leads to greater clinical comfort, is to move directly to a covered stent. And that was successful, placing it right below that RV marginal to avoid covering a major side branch. Second case, we had a circumflex. These are, of course, always some of the hardest. We were approaching a complex CTO, stent jailed about the ostium. It had a retrograde inlet from a graft that had a pseudoaneurysm, and effectively that led to a retrograde perforation that was necessary to cover with coils. So I'll just conclude that as managing complications is a critical part of what we do. It's very important to be prepared, recognize that these can happen, to have a toolkit in place, to have your systems of support in place. That means partners and cardiac surgery. And then most important, to stay calm during these procedures and just work through a systematic algorithm. Thank you so much.